Hi everyone, this is Dr. Annie Rutter. I'm the Clerkship Director for the Family Medicine Clerkship at Albany Medical College. Thank you all for agreeing to work with our medical students for this upcoming academic year. My hope is that this PowerPoint show will help you a little bit get ready for working with the students and prepare for a great year ahead. So by the end of this session, those of you who are participating will be able to really describe community precepting and what that means for medical education. Also to implement strategies in your own practice for incorporating medical students, as well as understanding the structure of the family medicine clerkship here at AMC. So when we talk about community precepting, what do we really mean? And we're really talking about physicians in the community who are working with students in this community setting, usually without full-time faculty appointments and serving as teachers, mentors, and role models. And why is community precepting so important? And we know it's important because most patients are receiving care in settings just like yours. The reality is that most physicians are not providing care to patients in the tertiary center like Albany Med, but instead in community offices on a day-to-day basis. So what are some of the benefits of community precepting? First of all, you get to teach the future of family medicine. The other is that you will receive up to 20 prescribed CME credits per year through the AAFP for those of you who are board certified in family medicine through the ABFM. You also get the bonus of a faculty appointment, and here at Albany Medical College that means you'll be a clinical assistant professor, and with that comes electronic resource access, including such sources as UpToDate, The Lancet, JAMA, and other journal articles. Preceptors also describe that it helps stay up to date when they're working with medical students. It helps them learn about resources and even helps them recruit future practice partners. So in preparing for the student's arrival, one of the most important things to do is really know the players. So what level of learner is my student? What prior experience have they had? What has Albany Med done to prepare them? It depends on the time of year a student is coming to work with you, but it also depends on what level of learner. All of the learners here at Albany Med for the clerkship are third-year medical students, with the first 2 years really spent in the classroom. During that classroom time, they do have experiences in clinical skills, working with the simulation center, practicing histories and physicals, learning procedures, and doing other things, as well as the medical knowledge that's important for working in a clinical setting. In order for your office to know more about the players, they can get in touch with our coordinator, Karen Frankenfield. She can help work out some of the logistics, and she's really the direct link to the students. As a preceptor, what you can do is really review the course objectives, the evaluation process for the clerkship, and really familiarize yourself with the students' assignments. These things will be provided in documents to you prior to the start of any of the clerkships. Prior to the clerkship, the skills that the students review at Albany Med can be really important to help you understand what a student will be able to do in your office. As a reminder, the academic calendar starts in July. So for those of you lucky enough to have the beginning of the year, July 5th is our start date for 2016. They do review a lot of skills that are learned in a simulated setting, and these are expected to be done with supervision. They have 2 prior years of practice with history and physical exams, as I stated before, with standardized patients. They also get to practice on patients in the hospital with the guise of a mentor as either a 4th-year student or an attending physician. They learn how to take vital signs. They practice with pelvic exams as well as suturing, injections, and needle safety. And they also receive a lot of guidance on motivational interviewing, including talking about such very common things in primary care as obesity, addiction, and smoking cessation. The next thing we will focus on is working with the students in a clinical setting. There are a lot of different aspects of patient care that students can become involved in. Prior to the clinical encounter, it's extremely important to orient the students into your practice. Let them know how patient flow works, introduce them to the members of the healthcare team so that they can learn and understand what each person does to help make the patient experience what it is. Also, set the agenda and expectations with the students. Are they going to be shadowing for this first couple of visits, or are they going to be seeing patients independently right from the start? And certainly it's important to talk about when to transition from one to the next. Very often students will be very comfortable with shadowing in the beginning, but in order for them to assess their own skill set and for us to be able to really see where they are as learners, we need to push them to the next level and see patients independently. Also really important to discuss with them when and where questions are appropriate and how and when feedback will be given. But what about the role a med student can play in the office? There's lots of things they can do. Before the visit, students can participate in things such as pre-visit planning. They can check the EMR for health maintenance screening, immunizations, what labs are due. They can even call the patients in advance of the appointments. They can meet patients in the hospital prior to discharge. They can call for updates. They can call specialists, hospice nurses, home care agencies, inpatient teams. They can call the patient at home and see what else could be going on and prepare for the upcoming visit. During the visit, there are a lot of roles that students can play. Traditionally, we think about a student going into the room, taking the history, taking the physical, coming out, presenting to the preceptor, but there are lots of other things they can do that are valuable to their education without being overly time-consuming for you as the community preceptor. So they can help your nurses room the patient. They can take the vital signs, document in the EMR, perform medication reconciliation, not only with the patient, but even call the patient's pharmacy. Perform procedures, EKGs, immunizations, phlebotomy. They can give your common patient education talks, and this can include things like URI, constipation. They can use their motivational interviewing skills. They can always do the traditional, take a history, and perform a physical exam. They can also help you with meaningful use measures, printing out clinical summaries, providing patient education, shared decision-making handouts. And you and the student can see patients concurrently. A student does not need to see every patient in order to gain a valuable experience. It's really important for a student to see several patients independently, but 2 to 3 per half day is very reasonable. What about after the visit? There's lots of things a student can do in this role too. Answer patient questions. They can do phone calls with you or with the triage nurses. They can call the patients after the visit for follow-up. How are you tolerating your new medication? What changes have been made by your specialists? Provide care coordination by going with the patient to a specialist visit. For example, you refer them to cardiology. Patient can be accompanied by the student to that cardiology visit, and then the student can report back to you with accurate information. There's also a lot of opportunities for population management, helping with your gap list, making patient phone calls for follow-up on things like mammograms and other screening tests. They can also help you create handouts. So how do you incorporate teaching into your patient care? Teach about the patients. You don't need to teach everything about every patient. The students are such sponges. They would be happy to learn about diagnosis, pearls of wisdom about management, but not both. You can do one or the other. Remember, you can have students read about specific topics. You can provide them with pearls of wisdom. Teach physical exam skills in the patient room. This could be after you directly observe the student or having them watch you. It's really important always to directly observe students and give directed feedback. This is a huge part of what we do as educators, and if you don't directly observe the student, either giving advice to a patient, performing a physical exam, or performing a history, it's really hard to assess them at the end of the clerkship. The 1-minute preceptor is one strategy for helping to incorporate teaching into patient care. It's a 5-step approach. The first thing is get a commitment from the student. Commit to a diagnosis, commit to a management plan, but get a commitment. Then probe for supporting evidence. Why did you pick that diagnosis? Why is that part of your management plan? Then teach a general rule. For example, they committed to a diagnosis of sinusitis. They said that they thought the patient had sinusitis because of unilateral facial pain, and then teach a general rule and tell them, every single time that I see a patient with sinusitis, X, Y, and Z is part of my counseling for that patient. Reinforce what was done right. You took a great history. You learned about this subtlety to the physical exam. And then whatever mistakes they made, make sure you follow up and correct them in real time. So what about the family medicine clerkship specifically at Albany Medical College? It's one of 6 required clerkships for 3rd year. It's a total of 6 weeks. the first 5 weeks in a community practice, and 1 week back on campus for the capstone teaching week and their final testing. There are several required assignments which are listed separately in a separate document, but a few of them include Family Medicine Cases, which is an online virtual case bank that covers required topics. If you, as the preceptor, go through these FM cases, you can receive CME credit. Patient logs. The students are required to track each of the cases they see throughout the clerkship. And then a community health assessment, which is a public health issue assessment for your practice community. It's a short paper with data and an interview in order to support their concerns. They also have several final assessments. One is the clinical evaluation completed by their community preceptor. The other is an OSCE, or Observed Structured Clinical Exam, with standardized patients here on campus, and then a multiple choice classic exam to assess their knowledge base. The clinical evaluations are extremely important and must be based on specific behaviors. Your goal as the preceptor is to not assign the grade, but really just report on what you saw. These two specific ways to give feedback and to do evaluations are: one, the midway feedback form, which directly informs the final evaluation. This is an opportunity halfway through the clerkship for you to give directed feedback to the student and for us to document that feedback. It does not influence the final grade unless those observable behaviors are not changed and the student performance does not improve. Final clinical evaluation is based on entrustable professional activities, which we'll talk about in just a minute. Again, it's extremely behavior specific. And if multiple preceptors are used, multiple clinical evaluations can be submitted to me, and we'll do the final collating of all the grades. Entrustable professional activities are a list of 13 activities that students are required to have prior to graduating from medical school. All 13 of these activities can be demonstrated and learned on the family medicine clerkship. However, a student does not need to master all of these skills during any of their third-year clerkships, but instead gain towards this final end prior to graduation. And these are listed here. This is a list of activities put out by the AMC, our overarching accrediting body for medical education. This is a vision of a scheme that can be used to assess where students are throughout the course of their third year with regards to their medical knowledge acquisition and skill set. So at the beginning of the third year, on the far left of the diagram, it shows that a student should be well organized with focus on history taking and obtaining detailed information. Throughout the course of the year, the student should begin to prioritize a clinical problem list and formulate differential diagnosis, with the end of the year really being able to integrate information with good time management and formulating treatment plans. In order to make sure the students move from the R on the left side, which means reporter, to the I towards the end of interpreter, there are several benchmarks that need to be met, and those are described on the bottom of this diagram. So the next question is, how do you stay connected as a community preceptor? By becoming a faculty member with us. So my name, Dr. Annie Rudder, and my contact information is listed here. If you had any questions throughout the course of the clerkship, please feel free to contact me directly. Karen Frankenfield is our go-to academic coordinator, and her email is listed below, as well as her phone number. If you have any questions, please don't be a stranger, and thanks for teaching our students.